Well, good afternoon or good morning, depending what part of the country you're in. This is Alan Miller with Cope Health Solutions, and I'm very pleased to have you all here today with our partner Aon and ourselves. And we're going to be talking about some of the really interesting and exciting things coming out of CMS, and CMMI right now with relation to a number of initiatives they've been undertaking for some time now to move the market more toward value-based payment, and some of the changes that have come down the pike from them around flexibilities, timing, and opportunities with some of their value-based payment programs. We're not going to hit on all the different programs today, and there are many that they're talking about with relation to flexibilities and opportunities to join those programs. And we're more than happy to help folks after this if you have specific questions on some of the other programs coming out of CMMI and CMS. Today we're going to focus more on Medicare Direct Contracting and the Shared Savings Program and how those would fit into your overall strategy. Let me start by introducing my colleagues, who I'm really pleased to have a great team with us today. So Brent Hardaway is one of our principals here at Cope Health Solutions. Brent's got over 30 years of experience working in all different areas of healthcare organizations and consulting. He's a very deep strategist and planner, as well as implementer, particularly deep experience around Medicare ACOs, clinically integrated networks, physician alignment, and now Medicare Direct Contracting. And he really has been key nationally to helping health systems chart their course into value-based care. So we're really excited to have Brent here. Dr. Andrew Snyder, another principal in our firm and our chief medical officer. Andy has some of the deepest experience in the country around managing and planning for and implementing value-based payment contracts, all the way from shared savings, upside only with quality, to full capitation, the California restricted Knox-Keene model. He's been the chief clinical integration officer at Mount Sinai Health System. He also founded a clinically integrated network of 3,500 physicians with them in New York, and oversaw a number of clinical programs. He also had an IPA that he ran with over 1,700 physicians, serving more than 400,000 patients in Northern California. Just a preeminent expert, whether it's physician compensation, developing risk entities, kind of the ingredients you need to be successful in risk, utilization management, and physician alignment. So very happy to have Andy on board as well. And our partner, Christina Mendez. Christina is also a foremost expert in reinsurance. She's the Senior Managing Director at Aon Reinsurance Solutions, which itself is a leading reinsurance intermediary and also a capital advisor. And Christina leads all of their managed care reinsurance solutions nationally. She's our go-to expert to help folks think through how to leverage reinsurance to be successful in risk. So she's been doing this for over 18 years. She works with all different types of managed care organizations across the country, really putting together reinsurance and stop loss programs. She's an expert in where the market is today and what tools are available. Prior to Aon, she actually founded a Los Angeles-based reinsurance firm and also led the managed care reinsurance business for Towers Watson. So really pleased to have Christina with us today as well. So a little bit of housekeeping. For those of you who may not have been on with us before, you can enter questions through the Q&A feature in Zoom. Andrew has a picture of it here for you. You can also email questions to info@copehealthsolutions.com. After the webinar, we'll collect all the different questions. There were actually some sent ahead of time, any that you submit during the webinar. And we will put together a written Q&A, which will be sent out, along with a PDF of the PowerPoint and a link to the recording. We'll also send you a brief survey right after the presentation, which we'd appreciate if you'd fill out. If we have time, we'll answer a couple of questions on the webinar, but again, if we don't get to them, you'll get the written Q&A afterwards. So here's our agenda. We're going to talk a little bit about what's happening with value-based payment in the current market today, think through Medicare Direct Contracting and what is the strategic opportunity for that. How do you build a successful value-based payment strategy? Because Medicare Direct Contracting, of course, shouldn't drive your strategy. It should be a part of it, as should shared savings, depending on what type of organization you are and where you are in your roadmap. How do you mitigate financial risk exposure so you can be more comfortable participating and be more successful? And finally, we'll close it out. And again, if we have time, we'll do some Q&A. So let's talk about what's happening. Despite or sometimes because of the COVID epidemic, the momentum toward value-based payment and capitation has continued to grow. Now, prior to COVID, Medicare Direct Contracting had already come out. It was the first time we've seen the federal government, outside of Medicare Advantage, of course, or the Medicaid managed care they've encouraged at the state level, come out with a capitated program, very, very close to the California model of capitation that some of us are used to. We were really excited when that came out. And what's happened since then now is that they have actually pushed back some of the deadlines, created a new letter of intent and application window. So that's part of what we wanted to share today, is that folks who may have been thinking about participating but hadn't had a chance, COVID might have slowed you down. There's an application due July 6th, but you may not have had time to really deal with that and think about it. There's plenty of time now to prepare for 2022, and so that's part of what we want to talk to you about today as part of this webinar. There also is other regulatory relief coming down the pike that really helps with success, potentially in risk. And when I say coming down the pike, the regulatory relief is here. What's coming down the pike is, are they going to extend that regulatory relief? And so we'll know more about that soon, but the feeling is that quite a bit of the telemedicine and other regulatory flexibility around, developing clinically integrated networks and collaborating across different hospitals and doctors, we feel a lot of that's going to stick because the federal government's going to take advantage of things moving in the right direction, so long as people are getting to risk. The other thing we're seeing is that with flexibilities, even with relief dollars, the feds are beginning to tie a lot of these things to taking risk. So again, they're capitalizing on their movement over time toward more Medicare Advantage, more Medicaid managed care, Medicare Shared Savings going to downside, Medicare Direct Contracting. And they're saying, look, if you want to take risk, we want to help you. And so we're just seeing this constant movement, COVID or no COVID, toward the government pushing for more value-based payment. The other thing that happened during COVID is that folks who weren't capitated, who were allergic to it, who were scared of it, if they had a chance to look across at people who were capitated, what they found was that people who were capitated on the provider side did very well during COVID. Because when you're capitated, you're taking risk for utilization. Utilization went down during COVID almost everywhere. And even in places where utilization went up for COVID, it went down for other types of ambulatory procedures and non-urgent procedures, electives. And so therefore, most folks at risk, both health plans and capitated providers, did pretty well. And so other folks are saying, well, how do I get involved with that? That sounds like a nice way to keep myself going during these types of epidemics. And we all know that COVID is not going away anytime soon. And finally, we think it's important, therefore, for providers and health plans. And for those providers on the phone, what you should know is that the health plans are very aggressively looking at Medicare Direct Contracting as well. There is a type called geographic that we thought a lot of health plans would wait for. But what we're seeing nationally now is that some of the health plans are not waiting for the geographic option, and they are jumping into Medicare Direct Contracting, which we think can be very positive for a lot of the providers those plans are working with, allow more collaboration. And so providers should be looking both at themselves and their plan partners when they're thinking about these opportunities. So I'm going to go ahead and hand it off to Brent.
Great. Thanks, Alan. Good afternoon to some of you. Good morning to others. As Alan mentioned, I'm going to be discussing Medicare Direct Contracting as a strategic opportunity, but also to pivot off of his earlier statement, I'm going to provide some information about how both CMS and CMMI are continuing to build and modify payment models that incentivize providers to move into risk, which of course, as we know, means there is less risk for the Medicare program, which is the direction they want to head. On the left side, you'll see information from the CMMI announcement that came out the first of this month for the Medicare Direct Contracting Program, and that they reopened opportunities to submit a letter of intent to participate in MDC for a start date of April 2021. So once the LOI is submitted, you'll have access to the application portal. Unfortunately, they did not open the window very wide, as Alan mentioned, and those applications are actually due July 6th. But fortunately, they also announced a second cohort, which will start in January of 2022. We don't know for sure, but we expect that application period will open in the first quarter of 2021. The flexibility with this adjusted timeline allows groups the additional time they need to assess whether or not direct contracting is something that makes sense for them. And we'll talk in a minute about some of the questions to ask as you're making that decision. To further illustrate the point that CMS is doing a lot to generate flexibility, on the right side, you'll see what they have done to provide guardrails to assure that that current Medicare ACOs are not liable for significant downside risk during the pandemic. So the interim final rule that came out May 8th did a number of things, including removing COVID-related costs from MSSP performance during the public health emergency, or the PHE, which started in January and currently runs through July 21st. There is some expectation that that will be extended. They've also said that during the PHE, the ACOs will not be responsible for shared losses. So if the PHE were to end in July, then the ACO would only be responsible for 7/12 of their losses. If, though, the PHE were to be extended through the entire year, then all shared losses would be forgiven. There's also an extension of time to report quality metrics and other modifications for quality reporting if the ACO is not able to report at all on some of those metrics. Another component of the temporary change is that current MSSPs can continue in their current risk track for 2021, and that means they don't have to move to risk next year if they were going to have to under their current contract. Also, there is a 1-year extension given to those ACOs whose agreements ended in 2020, and that extension will be at their current level of risk, and it will also maintain their current contract benchmarks. A couple of other things. One, the interim rule allows telehealth visits and virtual check-ins and e-visits to count towards beneficiary assignment in the attribution methodology. This is important because ACOs could lose significant attribution if only face-to-face visits counted, which has been the case in the past. One other thing, no new MSSP cohort in 2021. Next cohort will be starting in January of 2022. And as an aside, next generation ACOs, which are under the auspices of CMMI, they're making similar changes as I described for the MSSP, but also they have capped the gross savings upside. So that takes away the opportunity for huge windfall savings payments. Bottom line here is that CMS is doing what it can to guard against potential negatives of being in Medicare risk contracts during the pandemic. And as Alan mentioned, they're also contemplating providing even more incentives to get into APMs and making those vehicles more attractive to even more providers. Delving a little deeper into the specifics of the Medicare Direct Contracting program, one of the objectives of the program is to bring new entries and new provider types into performance-based risk in traditional Medicare. So they've developed 3 models for becoming a direct contracting entity, or a DCE. There's the standard model, the high needs population model, and the new entrant model. Your determination of which of these models to apply for depends upon a lot of different variables, but a couple to be aware of. One is how many Medicare beneficiaries, how many Medicare beneficiary lives do you think will be attributed to your DCE? That's a function of how many providers you have in your network and how large their Medicare fee-for-service panel is. In addition to that, how many beneficiary lives do you believe might choose to be in your DCE? And that's voluntary attribution, and we'll talk about that more in just a minute. Another variable is how much experience you have in alternative payment models and in taking risk. And then a third variable that you need to be thinking about is the level of complexity of the patient population you serve. That will determine if you want to choose the model in the middle, the high needs population. Only consider choosing this model if you have a highly evolved, or you can develop a highly evolved care management system for complex patients, because this can be an extremely costly population to care for. So in addition to the 3 models, there are 2 levels of risk and 2 types of capitation. On the left side, towards the bottom, you can see there's professional risk and global risk. And along the top of the 2x2, there's primary care capitation and total care capitation. The professional level of risk offers the lower risk sharing arrangement, which means that the DCE shares in 50% of savings and or losses, whereas in the global cap or the global model, the risk scenario shares 100% of savings and or losses. In the professional model, you can choose primary care capitation. In the global model, you can choose both, either primary care capitation or total care capitation. In primary care capitation, the network will receive a monthly payment that's approximately 7% of monthly total expenditures for the population that's attributed to you. That's for a specific set of primary care-based services. For any other services provided by the PCPs and anyone else in the network, they'll continue to be paid fee for service. Let's see, there's a lot more complexity inside these models that we're not going to go into here, like claims reduction options and historical and regional expenditure blending. But if you have any questions about the inner workings of the models, please reach out and ask questions. We have a number of white papers on this subject that you can find on our website. Next slide, please. The direct contracting model can be thought of as an amalgamation of the Medicare Advantage and the Medicare Shared Savings Programs, and even the next generation ACO model. There are a number of similarities between the models, and also some modifications that make the direct contracting model potentially more attractive. I'll just point out a couple of things on this slide. First, you can see under Medicare Advantage, the third bullet reads true network management and provider contracting. Under the Shared Savings Program, the last bullet reads no direct network management and contracting. What we mean by this is that under MA plans, there are restricted networks in that there are in-network and out-of-network benefits. Under shared savings, there is no network management, meaning an ACO patient can go to any Medicare provider they wish, same as traditional Medicare fee-for-service. Now, under the direct contracting model, you can contract with providers to be participants and or preferred providers, and you can create significant alignment with compensation and incentive plans, but you're still unable to modify the benefit plan for in-network versus out-of-network benefits, meaning that even though the DCE is taking capitation, it can't formally control where patients seek care. It can more informally make referral suggestions. So that certainly is a risk, and therefore risk amelioration strategies need to be defined as you contemplate applying for the program. So if you take nothing else out of these few slides that I'm going through, we hope you think of Medicare Direct Contracting as one component of your total value-based care strategy. This truly is a growth and a scaling strategy. It allows you to grow Medicare membership by aligning with providers in your market, but also one of the really nice attributes of the program is that it allows for voluntary attribution, meaning that in addition to claims-based attribution like we see in the MSSP, the DCE can actually market to potential beneficiaries and provide supplemental benefits that are not part of the typical Medicare fee-for-service benefit package. One other thing I'd like to point out on this slide is the third icon on the left-hand side, enhanced cash flow and first dollar savings. The monthly capitation payment certainly helps with cash flow as you're building your population health infrastructure. But additionally, and this is particularly important for those who have been in Medicare Shared Savings Program, where there's a minimum savings rate. In 2018, which is the latest publicly available data, there were approximately 160 Medicare Shared Savings Program participants that generated savings but didn't receive a shared savings check because they didn't meet the minimum savings rate. That won't be the case with Medicare Direct Contracting. So what questions should you be asking as you contemplate moving into Medicare Direct Contracting? We think that these questions fall into two categories, the market and organizational considerations. Under your market, you should be assessing the demographics of the Medicare population and how many are already in an MA plan, how many are in MSSP, and how many are in other APMs. That'll give you a sense of the potential market size. Also, what are your competitors doing? And we mean competitors in the traditional sense, like other health systems and other provider groups, but what about new market entrants like physician aggregator groups like Aledade, Privia, Optum? Are they developing programs and plans that are drawing Medicare beneficiaries away from your providers? On the organizational side, do you have an existing Medicare Shared Savings program? How has it performed? If it has generated savings but not shared savings checks, then MDC is a really, really good option. Also, you need to be thinking about things like your provider network and how you might be able to grow it and provide enhanced alignment mechanisms to your providers. Can your financial model, or can you financially model your current value-based contracts and arrangements? Are you able to ingest and transform claims data and manage and analyze and make information available to providers and care management teams? Do you have a functional and effective care management solution, and have you thought through other risk amelioration strategies like stop loss and reinsurance? I'm going to stop here and let Andy take over and talk about some of the tactical components that are necessary to make sure that you can be successful in risk-based models. Andy?
Thank you, Brent, and good afternoon, everyone. I'm just going to talk a little bit about building the successful VBP strategy. It's not new information necessarily, but this is really foundational and ties into being ready for risk transfer, such as direct contracting entities. So as you're assuming financial risk, I set up a framework, the ABCDs of risk transfer. And to go through that, this is set up as a framework where the A is alignment of physicians and network. And here I hope to make the case for compensation reform. As Alan was alluding to and Brent was speaking to a bit with direct contracting, capitation did very well recently and will likely do well going forward when done properly. The B is to have the right business and operating models in order to run a value-based system. You need the infrastructure, the data, the analytics, the care management, the outreach, and the business model is more about the internal strategic decision of your system, your group, your hospital. That value is truly the direction you're going in. and the reason I say that is because many systems still are obviously hybrid between some value-based contracting and fee-for-service, and they're not willing to move over the fence, and that they will still hedge the bet that they'd rather take the fee-for-service volume than collect any shared savings that may or may not occur. I understand the hedge, but it is certainly hindering the advancement of value-based care. So we're going to talk more about that in alignment as we go forward. The care model for C is really sort of logic games. If you do A and B, then C should occur. And what I mean by that is if physicians and practices were truly aligned around value, and the actual delivery of care would look different. It would be less transactional, much more longitudinal. Documentation would be more about the frequency of communication than about filling in a level 1, 2, 3, 4, or 5 visit just to drop a code. There'd be more email, more text, more telehealth, more virtual health. So when I say A plus B would lead to C, is that if you align the physicians properly and they're given the infrastructure and the business incentive to do it, they will organically create the right care model. Instead, we are pushing upstream with physician engagement strategies as opposed to aligning them fully and allowing the care model to develop. And then finally, if you've done A, B, and C well, you should be ready for D, direct contracting, or other risk-bearing entities. The D was just, convenient. So one thing though is that this is a complicated roadmap to get here. I would say don't worry that if you don't have it all built. I don't know anyone actually who has it all built well under A, B, and C. But this is where a partner can really help, who can help strategize, prioritize the costs, and actually help you manage through sensitive issues like compensation reform, which is very difficult internally at many organizations. But getting those foundational blocks built will allow you to be successful under value. So we're going to dig in a little bit into these. So on alignment, it's really about the optics and the mechanics of capitation. So when you look at how physicians are being paid and how systems are being paid across these various hybrid contracts of value and capitation, even under pro-fee, cap, dual risk, full risk, all of them are optically value-based contracts. They're all part of advanced payment mechanisms. But the underlying mechanics remain misaligned. For example, if you take pro-fee capitation, PCP and or specialty capitation with that, providers there are constantly pushing against the current. All the downstream to the right remains fee-for-service and inherently in favor of volume. Even dual risk, when facilities take risk, as I said when I was explaining the B in the last slide, they tend to make the business decision to continue to be paid fee-for-service. They'll true up at the end of the year. If they have savings, yay. If not, it's okay. They push for volume anyway. So that is the inherent misalignment that keeps occurring in the mechanics of value-based care, even though the optics of many of these programs seem like they're under advanced payment mechanisms. Some of those lead to real problems, right? So we're asking providers to fix the value equation by sort of quality programs and little incentives, but they're truly against all odds. And that's actually, and not to be too sarcastic, but that's a best case scenario. Because actually in most places around the country, most physicians aren't capitated yet, which is why Medicare is pushing a direct contracting strategy to try and push this agenda along, because it makes a lot of sense. Yet, while most are not under cap, and even those that are, everyone's pushing upstream against fee-for-service entities downstream. And we expect PCPs to drive value right, for this small quality bonus. I'm not surprised. I don't think anyone should be surprised that value-based success has been spotty across the country. Most have not done the alignment necessary to affect the change that we're looking for. It seems simple, but it's not. So in the business and operating model, the idea is to develop those core competencies in the supporting structure for value-based care. As I said, value-based care would look differently when done sort of full tilt. So do you have the network and alignment vehicle that can effectively impact provider behavior, patient utilization, and quality outcomes? That alignment vehicle, make no mistakes, that's a financial compensation vehicle that's also needed, besides the legal framework, obviously, in the organizational structure. Do you have the position, the experience, and the resources to negotiate favorable provider contracts? We are all amidst these hybrid contracts, and we need to move down that path, and each step sort of has its own flavor of what can benefit or hinder providers from success. Do you have functional, scalable, and effective care management solution? That's been touched on before. I would add the scalable part is really important here, and usually people scale out of it because it costs too much from a pure FTE standpoint. So we have to be smarter about care management, use tech smartly, data smartly, and really target our interventions much better than we're doing currently. Do you have the capability for delegation for utilization management? In this case, utilization management is referring to the prior authorization process and making the decisions about medical necessity. And plans tend to have done this around the country, except for mostly in California and models like that, where if you're assuming more and more of the financial risk, you should be making more and more of the decisions. It's another misalignment if you're now taking the risk, but someone else is making the decision if that procedure should happen or not. So moving to becoming delegated is a whole process in and of itself. Are you able to financially model your VBP arrangements and projected performance? Again, really tricky for even some of the more mature systems. Financial systems to date in healthcare have been very transactionally based. That's the DNA of all the financial systems out there. And getting into these hybrid situations makes it even more complex because you can't just flip the switch and look at capitation either. You have to be able to do both and bring that all together and understand the total impact of your care and your delivery. So that's been very tricky for many organizations as well. And are you able to transform those claims data, manage, analyze, and make the right data available, right? That's very key. Nothing happens. You can't fix what you don't measure, right? So you have to have the data available to you. We move on to the C, the care model. And this is having that clinical delivery model that drives value. And as I said, if everyone was truly undervalued or undercapitated like contracts, the delivery would look different. The foundational patient-physician interaction would look different. So what you want to do to get there is are you, first of all, optimizing the existing processes? Are you looking and scaling your care management efficiently? Are you doing the practice transformation work so you're expanding your ability to take on more patients through team-based care, closing gaps more efficiently by doing pre-visit planning, and doing the right population health management surveillance with your data and outreaching smartly? And can you look at your own patient population in various ways to understand the needs of your population in a very targeted, discrete manner? So that's getting through what you currently have. You also want to launch and expand new processes. And we've been learning a lot of this recently, that through COVID and the lack of the ability to go into offices clearly disrupted the supply chain of healthcare. So comprehensive telehealth solutions mean something more the past few months. It is not having just a tele-urgent care solution or telebehavioral health or telediabetes. You have to be able to speak with everyone virtually as needed. And that's a much bigger, different type of network solution that's linked to documentation and everything else you need to manage patients. You want to have scalable new networks. We've talked about this in some of our past webinars. With what's going on now through the crisis, with many people losing their jobs, losing their insurance through their employers, we will be sharing patients with FQHCs, with community-based organizations, much differently than we may have even if you're in the private practice world currently. We are learning much more about social determinants of health, and we're learning much more about how to take the data of that and make sense of it into from analytics to informatics, something you can actually use. Compensation reform is on the new bucket because most have not done it yet. I spoke about that for alignment, and developing those delegated competencies, as I mentioned. So the goals, again, here is providers and practices truly aligned through proper compensation reform would be engaged, right? Engaged to increase their panel size, because they're being paid per member per month now, not transactionally. Achieve measurable high quality care because it helps them access higher dollars and enable that team-based care to take care of a broader panel. That's what I mean. This would happen organically if they were aligned through compensation. And the delivery of ambulatory services would fundamentally look different, as I've said before. We have to look at the big picture. And before we get into the readiness sort of summary here of DCE, I want to just take a 30,000 foot view of the mechanics of population health, because systems and hospitals and specialists, as I said, stay misaligned from the providers who are trying to quarterback this thing. And the large-scale mechanics, the macroeconomics at play, is that population health management seeks to drive down the total cost of care. That scares specialists and hospitals, but it's meant to drive it down per capita, right? But those same mechanics, as I discussed, if people were truly aligned and not relying on volume fee for service, you'd be incentivized to increase your panel size, more people. So the goal is to decrease per capita, but there's always more people out there to serve. And with the amount of uninsured going on, I don't think that's gonna dry up anytime soon. So I think people need to understand the bigger picture in order to get past some of those hurdles we're seeing across systems. So in this readiness, you're looking at, telehealth we've talked about, not just the individual services, but a broad scale and acceptance of that. Payment terms restructuring, both contractual and physician. Utilization fluctuations, right? Leveraging your capitation and managing patients through other interventions that are less costly, keeping them more at home, and able to accommodate things that happen just now, like COVID, when they can't come see you at all. The innovative pilot programs, we talked about new partnerships, high-risk patient management, practice transformation. Those things need to be occurring in order to manage risk more and more. Brent mentioned some of the flexible provisions. We are in extraordinary times, and there may be more coming. And we want to be ready for that. This past wave, if we call it that, caught many off guard and obviously abruptly disrupted our supply chain. As I said, we can see this coming. Can we do better next time? And communication strategies. It's becoming more and more about communication and less about episodic care in general. And keep in mind with those flexibility, what we talked about is those current waivers, the current Stark waivers, the things that have gone on, the telehealth waivers that will be most likely extended, make it easier for immediate ability to invest in or get investment for, depending which side of the fence you're on, those A, B, and C building blocks. That's what you need the money for, to build those so you're ready for direct contracting. You have to keep a commitment for clinical integration going forward with those entities that are funding you, because that's the purpose of providing more efficient care going forward. So that's sort of the broad framework to lay out ABCs of getting ready for risk. And as I said earlier, most haven't done all of it yet, and certainly no one's optimized it yet and gotten full alignment across that whole spectrum of downstream payers. That's okay. It's a slow path, obviously, we're getting there. But in the meantime, there is financial exposure, and that's what's concerning many people. So while building the infrastructure helps you mitigate the financial exposure, there are also financial mechanisms to mitigate the financial exposure. So on that note, I want to reintroduce Cristina Mendez as a senior managing partner at Aon, who can talk about other mitigation strategies to layer onto your VBP roadmap.
Thank you so much, Andy. Really appreciate the opportunity to speak alongside the COPE team today. I mean, the COPE team is second to none in their thought leadership, so always happy to sit side by side with them in these discussions. So, what I'd like to spend some time on, just kind of rounding out the discussion, obviously there's, lots of opportunities here for you as providers and plans in many cases to take advantage of some of these opportunities around government programs and others. But what I'd like to talk to you a little bit about today is sort of, that evolving healthcare risk and what tools are out there, not only to address the risk mitigation, but maybe ways to think about your stop loss or reinsurance strategies in a more holistic way. Even perhaps, and we'll get a little bit more into market capacity and what some of those opportunities are specifically around, resources that come along with these programs, but an opportunity to really access resources in a way that helps your overall success as the risk-bearing entity. So the old idea of products, which is kind of what you're seeing here on this slide, is still in effect. Certainly market capacity has grown. We have a lot more creativity in the underwriting market. We also have some retrenching on some of the provider stop loss, but still, broad market capacity and folks still wanting to get in that. But if you think about stop loss and reinsurance, depending upon where you sit and which markets you have access to, really trying to, maybe open your eyes to how you might view some of these resources in addition to that risk mitigation as really kind of an addition to your arsenal to managing this care and this risk in a way that's more beneficial. And I'll get into some of those cost containment components as we get into the marketplace. But I know today we're focused on Medicare Direct Contracting, and Brent did a great job at outlining what the risk exposure is there. But it's a pretty exciting time for providers and plans. I'm sort of regional plan biased. I grew up in that space, and I've really dedicated my career to the success of community and regional health plan and provider offerings. So I think there's a unique opportunity here for folks to position themselves in the market, not only through government programs, but commercial risk programs that could really add to kind of your business goals and objectives. And also through some of the things that we're talking about, reinsurance stop loss being one. If you think about the level of sophistication, even in what COPE brings, for those of you that are fully familiar with the great work that they do with risk organizations, the access that you have to, kind of buy solutions to really help you be successful is great. I know there's certainly a place for the build, but there's some really great partners out there. So exciting time for you folks. So if you think about sort of these core, what I'll call managed care products, they can extend into the health community, but I'm really focused on the managed care market for Aon and the work that we do with clients and prospects. So some of the core programs are really designed around protection of your medical and pharma downside risk. And depending upon what type of legal entity you are, you could have access to traditional reinsurance, provider stop loss, and then, getting into some of the employer stop loss for your commercial initiatives around self-funded. The additional products that have really grown, have grown to include things like aggregate programs. That's typically more attractive to ACOs that are trying to beat a benchmark. That market has grown a little slowly, but the data quality out there has really allowed us to have a lot more robust discussions and underwriting interest in those programs. So the difference between maybe some of the core products that have been focused on following one of your single members, medical expense through a 12-month time period of accumulation, these aggregate programs are really focused on the overall medical spend. So really depending on how you have your contracts structured, we would be able to advise on which direction you might want to consider. So we have carve-out solutions. A lot of that follows some of the other alternative payment models that CMS has initiated, but again, following that very quickly into the commercial market around things like bundles, whether that be ortho, kidney, oncology, transplants. there's certainly a market for that. And then the one that's exciting for us is that specialty excess, which is really just what I get most excited about when I think about the conversations we can have. One client is one client. You're managing a lot of risk relationships, and so it's really important for us to be able to build a program that's specific to you, but this gives you an idea of what those products look like. And then, of course, the quota share, or sometimes referred to as capital solutions, would be happy to get into that a little bit, further, but those are still an important component to a health plan, mostly, but a healthcare organization that's really looking to free up some capital for things like growth and expansion. So, the healthcare market has shifted. This is a nice illustration of that all of you are living. I mean, it really is just a visual of where that risk has moved from fee-for-service, and certainly plenty of fee-for-service out there, but how everyone's kind of moving into that, capitation, performance-based, model. And that's really, where Medicare Direct Contracting, capitation, any of these downside risk programs live. And what's been, really exciting is, as the market has evolved and will continue to evolve, the reinsurance and the stop-loss market has also evolved. That market today represents about $700 million of managed care stop-loss premium, maybe a little more. And that has been, interestingly enough, split about 50-50. So if you think about, this managed care risk, downside risk, and what's being purchased in the market today, it's split pretty evenly between health plans purchasing that for the medical and pharma risk that they retain risk for and buying at, the appropriate levels for them. And then providers now buying stop loss for that assumed risk for those same services. So, from my standpoint, we're pretty agnostic to where that risk lives. It really is just more important to understand the nuances of how those populations are being managed and what that risk truly looks like. There's a huge opportunity, though, I think, for those of you that are either in these downside risks today or, thinking about getting into that, is really looking at this solution as, something that's just a little bit more than that risk transfer. And that opportunity really kind of lies around this kind of unique ability for the market to bring you value-added services that, again, go just beyond the coverage. Also a great opportunity for you to consider, your enterprise risk as you think about where do I have pockets of exposure today. Again, we're talking about Medicare Direct Contracting, but many of you have an inventory of contracts that you may be participating in. Some of those may be commercial downside risk relationships. Some of them may look just like capitation. Others might have, a little bit more color around them, but it's risk nonetheless. Some of you may be participating in joint ventures with health plans, doing private labeled offerings in both the self-funded and fully insured market. There's a whole host of arrangements out there that you may be participating in, and there's absolutely an opportunity for you to leverage your total footprint in the market. So if you think about how folks are purchasing stop loss, many, many times those stop loss arrangements are built into contracts. So there's a term, there's a fee, maybe it's a risk pool expense, but the commercial stop loss and reinsurance market, in addition to considering, the options that the payers are offering, really allows you to aggregate the totality of your risk. And many times it's a good exercise for us to go through with our clients so they fully understand the totality of each pockets of risk and what ultimately that all kind of drives up to. So thinking about your risk programs holistically is absolutely something that I would encourage as you approach the market, to evaluate the viability of these programs. So Brent walked through this slide. I just wanted to bring it back just so that we had an idea of what this downside exposure is. We don't have to cover the details. I think folks here are at least at a high level, familiar with what that risk is based on the option that you choose to move forward with. The important things here were really around the fact that, CMMI will be offering a stop loss program. It also offers risk corridors, so there's already some, built-in options for you to consider, but I still would really highly encourage you to evaluate commercial stop loss options. My understanding up to this point is that you will be able to opt in or opt out. The commercial market can bring sometimes significant cost savings on your overall premium, but there's, again, other components to this program that you should want to take advantage of, and I'll get into that on the next slide. But the last point, which is the last bullet on this, is that there will be a required financial guarantee for each of the performance years. Every state will be different, even though this is a federal program. It'll be interesting to see how they view stop loss or reinsurance as a financial guarantee. Might take a little bit of time to figure all of that out, but something to keep your eye on, and certainly this team here will continue to update those folks participating. I'll just end on, the market capacity. I gave you a little bit of color around the size of it in terms of, total premium spend, but when we think about stop loss and reinsurance, where we really bring value to you and where you should be seeking value is finding underwriting capacity that specializes in your business. And there are, this group of managed care underwriters, which I would say, could be as many as, 18, but maybe more like 13 markets. I'm not talking about the entire health market, but really underwriting capacity that really understands why you're not just managing a unit of cost, that you're managing, populations and really trying to manage the healthcare spend and quality of these members in a very different way. That unique underwriting approach has really added value, and that's really where you should be seeking some of these solutions through your broker partners. Obviously, we're happy to chat with you about that. But in addition to underwriters that fully understand how you as a managed care organization are trying to differentiate yourself, there's also been a large investment focused on cost containment resources. So as part of your treaty or stop loss coverage, you'll have folks now dedicated from a clinical and cost standpoint that you could use purely as value add. These are not delegated services. These are value add. Maybe you need some help with, complex care management. Maybe you need access to a broader network of specialized services, forensic bill review, more so when you're talking about DRG outliers or commercial business. But, again, moving beyond just sort of the price and coverage, which are absolute opportunities for you accessing, the commercial market, there are these services that really can add value to your overall program. And then I just wanted to leave you on, kind of some of the things I touched on before. If you think about the reinsurance and stop loss market, here are some examples of really, being more business minded, which is where we like to align ourselves with you as your advisor broker. The products are the products, but more so, as you continue to evaluate all of the exciting opportunities around risk, these are some examples of where those products and tools can be very, very beneficial to those discussions. And just wanted to end on that note so that you can have an idea of where to kind of position reinsurance stop loss in your thinking and sort of, your advisory team as well. So thank you. Alan, I'll turn it back to you.
Thank you so much, Christina. So first, I want to thank you all so much for being with us today. We're just close to the hour. I think that the takeaway message that I hope you all have come out of this with is that while value-based payment and taking risk is a complex business, it's also a business that has rules of the road, and it has critical success factors that are well-defined. There are lessons learned. We do know what works in most situations. And the federal government and employers and state Medicaid programs are pushing very, very hard. In fact, I just got off a text thread with a state Medicaid leader who was talking about how they really, even though their hospitals are not going to be excited about it, they want to push much harder to get people into value-based payment because of what's happened after COVID. So it's coming. It's possible. As Andy said, you really have to have the right ingredients in place. And I think the other piece to think about is there are partners. There are folks who are interested in partnering with you. You don't have to give it away. You don't have to bring someone with money and give away your entire population health management solution. You can bring a partner in to co-source with you. So with that, I'm going to wrap up. Just a reminder for folks that we will be sending a tape of the webinar. We'll have a PDF of the PowerPoint and also a PDF of the Q&A. We won't have time to get through Q&A today. I apologize for that, but we thank you very much for being with us. We hope you all stay very safe and well and are staying out of the heat. And with that, we'll call it a wrap. Thank you, everyone.